Welcome back to Medical Monday tonight. I'm with Dr. Dan Wonder, an interventional radiologist. We're talking about uterine fibroids tonight. If you suffer from these, you know it. Now's your chance to get some advice if you're searching for solutions. And we have some folks on the line. Let's get right to the lines. Rebecca calling in tonight. Rebecca, you're our first caller. Thanks for being on the line. What's your question?
Hi. Can you have uterine fibroids, endometriosis, and endomyosis all at the same time?
Yes, you can. You can. Endometriosis can't be treated with embolization, though. Endometriosis.
Okay, because I had it all straight, and I chose to have a hysterectomy at the time, and it was like the best thing.
Yes, ma'am. The endometriosis, you know, that's the lining of the uterus. It kind of gets out of the uterus and goes other places in the pelvis. And it can, every time your hormones change, then that proliferates. It causes a lot of pain. So yeah, that's a different deal. That has to be treated in the fashion you had it treated.
Now, most of your patients, are they just dealing with the uterine fibroids, or do you see kind of a stacking of issues?
Sometimes you get the fibroids and the adenomyosis. The adenomyosis is where the whole uterine muscle kind of gets infiltrated with a similar process to a fibroid, just kind of diffuse though. But you see that, and then we see some people with pelvic venous congestion where the veins don't drain out of the pelvis well enough, which causes pelvic pain too. So that's a kind of not a common combination. It's a little more common than the endometriosis.
Okay.
That doesn't usually end up showing up to me because that does get treated surgically. Yeah.
All right, let's talk to Livan. Livan, thanks for being part of the show tonight. What's your question?
Yes, I have had heavy periods, and they all of a sudden quit like 3 years ago. Then I guess I went on into menopause, and I was wondering if that is common.
To go from one to the other, or what?
Yeah, to go from one to the other.
Go from very heavy to nothing at all.
When you go through menopause?
Yes.
Yes, ma'am. That's pretty normal.
Alrighty.
All right,
okay.
Thank you, Livan, for calling in. Let's talk about the folks who show up in your office. And you said most people have been told you have uterine fibroids, and they start searching for solutions, you know, whether to do the hysterectomy or the embolization. They show up in your office. What do you then do?
The first thing we do, of course, we want to make sure that they have, if they don't have imaging of some sort, we get it, like an MRI or a pelvic ultrasound, to, you know, document what the fibroids, how big they are, how many they are. That's important as a baseline. The biggest thing, though, is their symptoms. I mean, we're treating their symptoms. You're not going to make the fibroids go away with an embolization. You're going to shrink them so that the symptoms stop or decrease. That's what you're trying to do. So you get the imaging. It's always good to have a recent pap smear that's negative, because the last thing you want to do is have somebody that comes to you that is bleeding, that really they haven't come from an OBGYN that has worked them up. You want to make sure you're not dealing with a tumor in the uterus or endometrial tumor that you're embolizing and giving someone false security.
Sure.
So those things are on the front end of things, basically. And then you know, we do a consultation just like we do with the kyphoplasties and the peripheral vascular disease, so we know their full history, surgical history, social history, all that stuff. And then we spend quite a bit of time, you know, we give them some materials, of course, but quite a bit of time just going over the process of how the embolization works, you know, what the day is going to be like at the office. They're usually there for about 4 hours. And then what the recovery is like, and when they go home. And that's probably the more important thing for them to understand. Because when you embolize a uterus, I usually tell the women it's going to be like you're having a very, very bad menstrual cycle, because that uterus, you're taking away the blood flow from it, pretty much the whole uterus, and so it's kind of screaming for something. And so we make sure that they're covered with you know pain medications of different sorts, and injections and steroids and all kinds of stuff to make that first evening better. And it's really, the scale is wide open top to bottom, as far as some women are like, hardly even noticed you did anything. And then I have one or two ladies that had quite a bit of cramping for almost up to a week. So that's not very common, but it happens. So
okay, so we know about the consultation now. Walk me through what happens the day of the embolization.
Okay, they have the embolization. They get prepped essentially like an arteriogram, which probably doesn't make any sense to anybody, but they come in. They get an IV. We give them antibiotics. They get some IV Toradol, which is an anti-inflammatory. They get sedated. we put a Foley catheter in them because you need to see the uterus, the bladder's in front, so that gets, when they're sedated, that gets done by my nurse. Then we sedate them. We put a needle into the artery after we numb up the groin on the side and steer catheters up into one catheter from one side, goes into the uterine arteries, which are in the pelvis, one on each side. We go over to the left side first, I usually do. We do an arteriogram. We see the arterial flow to the uterus and to the fibroids, and it's very classic.
So you're watching where the blood goes.
We inject just like a heart cath, same thing, but where it's the uterus. When we inject it, we can see exactly where the blood flow is, and then when we have that good map, we very carefully inject microspheres. They're tiny spheres, 300 to 500 microns in diameter.
Wow.
You can't even see them, they're so small. So we mix them with contrast, and then as we slowly puff that in, we can see how the blood flow starts to slow down as these little beads are stacking into those arteries and just packing them shut. And then after we get what looks appropriate, then we pull back and we go over to the other side and do the other side because they're fed from both sides. Now, so you basically embolize the uterus and any fibroids in there. And you've been very careful with where you put the catheter to avoid what we call unintentional embolization, which means we don't want any of those little particles to go to like the ovaries or to the urinary bladder or other things that are down there. We don't want to hurt those if we can help it. And then after we feel pretty confident we've got everything done, pull the catheter out, put a little stitch in the artery, Foley catheter comes out, then come into recovery. So that whole process takes about an hour-ish maybe, and recovery is about an hour. Then we discharge them with their family home.
And they're supposed to stay off their feet for a while, right?
No, they go home, they can walk out, they walk out the door.
Okay.
You know, because there's a stitch in the artery so they can walk. I tell them to go home, take it easy. They still have some sedation on board. We give them quite a bit of other medicine to have with them. So they go home and rest that evening. Tell them they can't drive for a day because of the narcotics in their system. Really no heavy lifting for a couple days, mostly because of the puncture site of the artery. And that's really cautious. It's probably overkill. But then we check on them that night, and about a day or two later we check on them again. And if, you know, if they're having any issues, we keep checking on them. But, you know, otherwise, they come back in about 3 months for an ultrasound, and then 6 and 9 months you can do either ultrasound or MRI, because you're going to see watch those fibroids. You want to see them shrink over time, and it doesn't happen right away. It takes, you know, up to 6 months sometimes, but you want to if you can see a shrinkage of about 20% in diameter, so if it's a 2-centimeter fibroid and you can shrink it down 20-30%, that's a 50% reduction in volume. So if you achieve that, then that's a great thing. So about 75, well, actually, it's more about 85% to 90% of women get good relief of their symptoms.
Just by shrinking.
Just by shrinking them without, you know, because they're going to still be there.
Right.
They're not coming out. And it's very rare to have to redo an embolization, but sometimes you do if their symptoms persist. Usually give them up to almost a year, and if they're still having symptoms, we can go back in and re-embolize.
Now, women who have had fibroids and do the embolization, are they likely or unlikely to grow new fibroids?
They can actually. It's not real common, but they can. So, and that's why, I mean, the embolization process, I mean, if you had to, you could repeat it, repeat it, repeat it. I mean, it's not the intent, but you can. It's not like, you know, surgery where you operate on something and there's a whole bunch of scar tissue. Next time you're going to go in there, it's going to be really hard. Embolotherapy isn't like that, where we put those particles in. They're going to flow to the area of most flow, and they're going to stop. So if you put them in, like you have a big fibroid that brings a bunch of those particles in and stops up the flow, and that fibroid goes away, and 3 years later the lady gets new fibroids, you inject again, it's going to direct to the newer fibroids that are because they make the vessels dilate so that they pull that blood flow to them. Is there a size that matters when it comes to the fibroids that makes somebody a good candidate for this or not? Initially, when a lot of this was, you know, ramping up in the U.S., they really wanted you to stay away from the real big fibroids, like the 20-centimeter fibroids. That's pretty big. Yeah. And we still try, you know, to let the people know that those are a little bit more troublesome. I mean, that's taking up space in your body. A lot of space. The reason being is that the bigger they get, and when you embolize them, they can outgrow their blood supply, and so the middle can get necrotic or infected.
Yeah.
So there is always that little risk. It's not big, it's less than 1%. But there is a little risk that they may still have to have a hysterectomy if they get an infection. So that's why they get preoperative antibiotics, they get go-home antibiotics, and when we check on them all the time, it's always, okay, are you having any discharge that isn't right, because that could be a sign that something's infected. But it's really rare.
Okay, good to know. Let's talk to Pamela on the line. Pamela, thank you for calling in tonight to Medical Monday. What's your question?
I would like to know if this procedure is recommended for young women in their 30s that would like to have a child later.
Okay, great question. Thank you, Pamela.
Very good question. We tell women on the front end that, you know, there is no guarantee that you will be able to become pregnant after this procedure. But
and why is that? Well,
because, you know, the endometrium grows off of the myometrium. It's all fed by the same set of blood supply. So, you know, that could inhibit reproduction potentially. And if you got any of those little particles in the ovaries, that could be, you could create premature menopause. Again, very unlikely. But there have been hundreds and hundreds of cases of women that have gotten pregnant after fibroid embolization. So, you know, most of the time we try to, you know, steer it to that population of people that are done having their children and having problems and waiting for menopause. But that doesn't mean that you can't do it to someone younger. I mean,
because what options does a woman have who still wants to have children but is dealing with very painful uterine fibroids?
Well, hormonal therapy, that would be the only one, you know, but that would affect pregnancy
your
too.
Fertility, yeah.
So there, it's kind of, I mean, probably if a woman that was 30 had, you know, an 8-centimeter fibroid on the top of her uterus and it was causing problems, the OBGYN would probably recommend that they go in and take off that one fibroid, a myomectomy. And that would be an option that you would weigh against fibroid embolization. And there's still risk. I mean, you have a myomectomy, there's a chance that you can have an injury to your uterus and you can't carry a child too. So everything we do has risk associated with it. And it's, I mean, no one can give you hard and fast numbers really for any of those, really, that, you know, you can have a 2% risk here or a 4% risk here. Everyone's kind of halfway guessing anyway.
Risk,
yeah, so I mean, it's doable. And, you know, I mean, the women, and the reason, part of the reason it's been proven, in fact, I had to do it probably a month ago, postpartum, 22-year-old lady, you know, bleeding, can't surgically stop it, embolize her uterus. I had to explain to her that, you know, I can't guarantee, but, you know, you may not be able to have children after this. But it was either that or a uterus was coming out. So she said, do it, please. I mean, I want to at least preserve everything I can. Right. So it's a little bit more extreme than what she's asking, but it's the same idea. So
it's one of those things that if you still want to have children, you just really need to have some good conversations with your doctors and say, okay, let's weigh some options here. And that's a tough one because you are taking a little bit of a guess and a little bit of risk every time. Okay, we're going to take another quick break. If you have a question about uterine fibroids, go ahead and give us a call tonight. 737+ is the number to call. We're coming right back.